A patient presents with persistently elevated liver enzymes. Viral panels are negative. Standard screening returns a positive titer for anti-nuclear antibodies, or ANA. For many specialists, this specific triad prompts a standard diagnostic reflex, ordering a percutaneous liver biopsy to confirm or rule out autoimmune hepatitis. International guidelines recommend tissue evaluation when autoimmune hepatitis is suspected, but these directives omit a critical variable. The guidelines do not specify the biochemical thresholds, specifically the degree of transaminase elevation required to justify the procedure. Treating a patient with an ALT of 80 the same as a patient with an ALT of 800 ignores the inherent risk of the biopsy itself. It subjects patients with mild biochemical presentations to the same procedural morbidity. Researchers at Heidelberg University Hospital analyzed 313 adults who underwent ultrasound-guided percutaneous liver biopsies, specifically to evaluate unexplained liver test elevations. Within this cohort, 61.3% of the patients tested positive for anti-nuclear antibodies. The objective was to map the actual diagnostic yield of these biopsies against the severity of the patient's initial lab results. The study shows that in ANA-positive patients without cirrhosis, whose alanine aminotransferase, or ALT, is below 101 units per liter, the biopsy provides almost no actionable diagnostic value. Isolating this specific mild subcohort allows us to construct a precise, data-backed threshold for exactly when a clinician should reach for the biopsy needle. The standard clinical reflex relies on the assumption that a positive ANA titer signals an underlying autoimmune pathology in the liver. The data contradicts this. This chart visualizes the primary histological differential diagnoses for the entire 313 patient cohort, split by ANA status. Drug-induced liver injury accounted for over 51% of the diagnoses. That dwarfs the red bars for AIH possible or likely, which sit at just 22.4%. This high prevalence of drug-induced injury occurs at almost identical rates, regardless of whether the patient was ANA positive or ANA negative. Histological findings of steatosis and steatohepatitis also appear at a higher frequency than autoimmune hepatitis. We can call this the ANA fallacy. A positive anti-nuclear antibody test in the context of elevated liver enzymes routinely misdirects clinical suspicion toward autoimmune hepatitis. In a real-world tertiary referral setting, ANA positivity alone is a poor independent predictor of true AIH. To isolate the utility of the biopsy, we have to stratify the ANA-positive cohort by the magnitude of their initial ALT elevation to find the mildest group. This flowchart tracks patient outcomes. We focus exclusively on the top path, 78 patients presenting with an ALT below 101. Following this mild group left to right against consensus criteria, notice the massive gray channel leading to the top node. 91% of the biopsies from patients with mild transaminitis yielded histology deemed unlikely for autoimmune hepatitis. Out of 78 patients, only 7 showed histological features compatible with possible or likely AIH. This diagnostic drop-off demonstrates that a mild biochemical presentation rarely masks a severe occult histological case of autoimmune hepatitis. Histology alone does not dictate patient care. We have to shift our metric of success and evaluate how these biopsy results actually altered therapeutic management. Moving to the rightmost section of the chart, we can track the clinical decisions made for the 78 patients in the mild ALT bracket. Only 6 of these individuals were given a probatory cortisone trial based on their pathology reports. Ultimately, only 3 patients out of the original 78, a 3.8% diagnostic yield, required the initiation of long-term immunosuppression. When we interrogate the clinical profiles of those 3 true positive cases, patient 2 and patient 3 had highly elevated IgG levels and strongly positive ANA titers well above 1,280. Furthermore, 2 of these 3 patients already had known compensated liver cirrhosis and elevated liver stiffness measurements exceeding 20 kilopascals before the biopsy was even performed. These results suggest that for patients without pre-existing cirrhosis, the likelihood of a biopsy identifying actionable AIH in the presence of mild transaminitis is approximately 3.8%. The predictive power of this threshold is validated when we contrast the mild cohort against the most severe presentations. Looking at the bottom path, we analyzed 26 patients with an ALT over 1,000. Here, the histological yield jumps, Possible or likely AIH reaches 50%, but watch those classified as unlikely. There is a divergence between the histological reading and clinical reality. Even with an unlikely pathology report, the majority of these severe patients were empirically started on corticosteroids, yielding a 100% biochemical response rate. This empiric treatment is driven by the recognized clinical overlap syndrome known as drug-induced autoimmune like hepatitis, where severe drug-induced injury mimics autoimmune flares. In high-severity cases, clinical empiricism often overrides the pathology report, calling into question the biopsy's utility to definitively separate severe drug-induced liver injury from true autoimmune hepatitis. The percutaneous liver biopsy remains a highly invasive physical procedure that ultimately requires breaching the outer liver capsule. In this study cohort, there were documented cases of post-procedural pain, hematoma, and hemorrhage requiring hospitalization and blood transfusion. Exposing a patient to that risk requires a high probability of uncovering actionable data. Clinical suspicion of autoimmune hepatitis, based solely on a positive ANA test, combined with mildly elevated liver enzymes, is often misguided. Instead of an automatic reflex, clinicians can defer the procedure by checking a data-backed patient profile. If the patient has an ALT under 101, is positive for ANA, and lacks signs of advanced fibrosis or other severe competing etiologies, the biopsy can be safely delayed. The procedural risk is justified when the ALT exceeds 100, when cirrhosis is suspected, or when there is strong clinical evidence pointing to a concurrent biliary disease. Precise stratification using ALT, rather than the reflexive reliance on ANA positivity, minimizes patient morbidity while ensuring the biopsy is reserved for cases with a high